Good morning and welcome to our monthly live broadcast for peripheral endovascular interventions from Mount Sinai Hospital from the Division of Endovascular Intervention in the Cardiology. Here, I welcome you. I'm Vishal Kapoor, here with my partner, Dr. Raman Sharma. We welcome you for another exciting session. So in our efforts to showcase various procedures, various disease processes and intervention in conjunction with other specialties, we have another great case coming up lined up today, a different kind for the endovascular, the specialists, the vascular surgeons as well to look into and discuss the management. Before we go into the cath lab, just a few house errands. You can watch our cases, including today's broadcast on our website, ccclivecases.org. Under the peripheral intervention tab, you can see all the archive cases, the presentation, our PowerPoint presentation as well, and you can assort it by different anatomical sections, femoral, tibials, popliteals, and aortic as well, for the interest you like. Also, just to remind you, I'm sure you saw or visited virtually or in person our first New York Endovascular Summit, which was held last year. So the idea is to keep the tradition on, and we are up for this year as well, God hoping. We're going to be doing our session from October 6th to the 8th here in New York City. The 6th will be our fellows course, which me, Raman, and Karthik will be leading, in addition to with Dan Hahn from vascular surgery, to help educate the fellows with our goal to present cases, discussions, have live sessions, including cadaver sessions and your hands-on experiences, which will be our focus this year. The 7th and the 8th October will be our endovascular summit, where we'll have all the faculty, renowned faculty from the tri-state area, from the nation, and even international faculty, hopefully, like I said, in person here. And the goal is to just get together, learn some, and have some fun.
Excited for it.
Yep. So thank you, Raman, for joining, and let's go into the lab. Morning, PK.
Hello,
Hi,
Mohammed.
good morning, everyone, and thank you so much
All
for
good.
joining. And it was a great introduction, Vishal and Raman. I just wanted to really introduce our team here. We got a really great case. To my left, just slightly behind me, is Dr. George Dangas, who's professor of medicine cardiology and professor of surgery and the director of cardiac innovation, and really just a tremendous interventionist and very well known to all of you, who is kind enough to actually bring his case for our live case here today, which is wonderful. And thank you, George, for joining. In front of us is Dr. Ajit Rao, who is also a assistant professor of surgery, vascular surgery here at Mount Sinai, and he's also very involved with our symposium, and also one of the co-directors of our fellows course this year. To his left is Twinkle Singh, who is our endovascular fellow along with Luke Murphy this year, and Twinkle's been carrying a lot of the work for this particular case. So thank you, Twinkle. Behind me is Ray Lascano, who's our endovascular nurse practitioner, who all of you know, and then Marichu, Elizabeth, and Damien are in the lab to help us, as well as multiple other people. So we have a very, very interesting case here, which I'm going to ask Twinkle to present in a few minutes. It's basically, it's a case that really involves what we all feel the endovascular field has evolved into, which is really multidisciplinary, multimodality approach with imaging, as well as really sort of a multiple thinking caps on board for us to be able to come to a appropriate way to treat this patient. Obviously, the data is lacking, and we're going to go over a lot of the data that is currently available with this particular case. But I think it'll be very good. Twinkle, you want to?
Yeah, let them. Maybe let them do the perclose right now. They haven't finished. Let's just give a little bit summary of how it came about the case, and then Twinkle is gonna present all that, because it's a little confusing, quite frankly.
Absolutely.
This case was initially referred for a CHF cardiomyopathy and possible pulmonary hypertension of in a relatively young person. And indeed, that seemed to be the case. Ejection fraction about 45%, a global mild hypokinesis of the LV, and indeed pulmonary hypertension by the echo. Then indeed there were some by exam some some interesting or funny, I would say, bruise around the cervical areas. But again, this might be concomitant disease, so nobody really paid that much attention to it before. So the patient came in for a right and left heart cath due to CHF in a young person, essentially. during the catheterization, we realized that there was bilateral subclavians completely occluded because we tried radial accesses. And then going from the groin, everything seemed to be okay, except that all of a sudden we realized that the central aortic pressure was 220. Whereas we're measuring in the extremities pretty much normal pressure, and the patient was also reporting no history of hypertension. So interestingly, it turns out that there was some type of a distal aortic stenosis, thoracic aortic stenosis. So all four extremities were underperfused. We're getting essentially a minus 60 blood pressures all over, and nobody knew about that. So the patient ultimately was diagnosed of having secondary pulmonary hypertension due to hypertensive heart disease with heart failure.
Wow.
And everything became then the workup of these very interesting stenosis all over. And, you know, there was some relevant vascular medicine as well as rheumatology consultations in anticipation of the different aspects of this procedure. Perhaps we can go to the slides. After I gave you this kind of I would say,
so Twinkle can give the history.
Just going to get the slides, and then Twinkle can give a little bit more of a detailed history and all that. If you got a bit of the overview, so you're not too much surprised.
So 55-year-old male, past medical history of hypertension, and there was a history of tuberculosis at age of 38 years, but according to patient, he had completed full treatment for that. He was, like Dr. Dangus said, he was found to have a EF of 45%, which led to ischemia evaluation. And on cardiac catheterization, we found that his coronaries were all right, a moderate lesion in RCA. But during the cardiac cath, we found that distal thoracic descending thoracic aorta had a lesion, and there was a gradient of up to 60 mmHg across it. And we also found bilateral subclavian stenosis, and I will show the angiograms. Medications wise, he was on amlodipine, aspirin, Crestor, enalapril, triamterene, HCTZ. His workup, because of all the occlusions and the subclavian occlusions, we were thinking of vasculitis. So he does have elevated ESR and high sensitivity CRP. His quantiferon gold was negative, and ANA was negative as well. So on exam, he did have a significant difference in right and left upper extremity blood pressure. He does have a loud supraclavicular bruit on right side and a soft one on the left. On abdomen, there is an epigastric systolic bruit, and on the back also a loud systolic bruit was heard between the scapula. And bilaterally, radial pulses were not palpable. But all the pulses were palpable, femoral and DP and PT. So this is the left subclavian, and the right subclavian, as you can see, both have total occlusions.
Wow.
Whoa.
So in abdominal aortogram, carotids look okay there, and then you see there's a lesion there.
Wow.
Okay. So we end up getting a CT scan. CT scan read that as a bovine arch. They measured ascending at 40-41. Right subclavian severe stenosis, left completely occluded, and descending thoracic aorta, they noted a lesion like it tapers down to 1 centimeters after a short segment and then resumes its normal size. Interestingly, no significant wall thickening were noted throughout on the CT scan. So measurements wise, proximal to the lesion, where the healthy segment aorta measured up to 2.2. Right at the lesion, it was 1.1, and the distal to it was 2.2. And there was significant amount of length above the celiac artery, at least 4 or 5 centimeters. But we'll do an IVUS and we'll get the more accurate measurements now. So we got rheumatology involved. Rheumatology did say that we just need to do close monitoring. They did recommend that because of the significant gradient, we should go ahead and fix that thoracic aortic lesion. And they recommended that we should start immunosuppression therapy after the stent. So our working diagnosis at this point is large artery vasculitis, and or possibly related to tuberculosis, as that can also present in late stages, mimic large vessel vasculitis.
Showed him before. Okay,
So
go ahead.
that's a case for now.
Yeah, let's stop there.
Yeah.
And I just want to go ahead. We're going to do, this is something very interesting because the surgeons, obviously our surgical colleagues are very, keen on understand the pathophysiology and how to fix this part of the aorta. But I think it's also important to go over all the types of syndromes that can cause this kind of situation in this particular patient. Obviously, it's not a very typical presentation as Dr. Danger showed you. And can you show the pressures, guys? We want to show you the gradient across the thoracic stenosis and why this guy is so symptomatic. Can you put up the pressures for us before we do it? Yep. So you can see the red line is the supra in the thoracic in the aortic arch, and the blue is in the common femoral, is actually in the distal aorta. So you can see it's a tremendous gradient. So anyway, so what we're going to do now is do an aortogram, and then we're going to go ahead and do an IVUS. But I just want to go ahead and then have Twinkle present sort of some of the background in the aorta and disease of the aorta, especially focusing on vasculitis and aneurysmal disease, which I think is kind of the most common things that we're going to see. So we're going to go ahead. Ready for the aortogram, guys? Before we do it, let the gang see the aorta. So the view we're going to get is.
AP.
Yep. Well, you want to go AP, right? Yep. I would go AP. Yep. Always AP, Flora.
And we'll do it from the pigtail.
Okay. Let's go AP here. Okay, we'll get a new AP. Okay, ready? So whenever you're ready, let me just fill the catheter, Flora.
That's okay. The catheter is good. Let's get
It is
another
filled?
one.
Okay. Okay, very good. All right, DSA. Okay, hold on a second. We're just checking everything here. So, yep. All right, we're going to put it as abdomen. That's fine. All right, and whenever, tell him to hold his breath, guys.
You flush it?
Can you just ask him to hold? Sir. Can you wake him up?
Mohammed, hold your breath.
All right, ready?
That's
Sitting.
one way to do it.
Shock and awe.
Oh, wait. I'm sorry.
All
One
right,
more
it's
time.
good to inject.
Go ahead, one more time.
The heart is going to move anyways. I don't know how much breath holding is. Oh, there we go.
Oh, good.
Wow.
Very
Good,
impressive.
good landing zone.
Okay.
Yep.
Good.
All right, so excellent. So before we talk about what we're going to do here, we're going to IVUS offline and have Twinkle start the presentation. Go ahead. Let's get the 10 French IVUS, guys.
Let's just make a comment here that in the previous workup of the imaging, the primary stenosis was noted, but the distal stenosis was a little bit ambiguous. So it turns out, based on this imaging at least, in one view, no significant distal stenosis, which is very good, and for reasons we want to explain later.
In the CAT scan, yeah, we'll go over that too.
Yeah.
But go ahead. Okay.
All right. I will first present an overview of general overview of aortitis. Essentially, that means inflammation of aortic valve, and commonly does cause aortic aneurysms and dissections. Broadly can be classified as infectious versus non-infectious and inflammatory. Clinically, aortitis has a wide spectrum. At one end, it can just lead to symptoms of back pain, abdominal pain, fever, and systemic inflammatory syndrome by vasculitis. On the other end of the spectrum, it can cause severe aneurysmal disease. With over time, it can involve coronaries and aortic valve and aortic root, causing aortic insufficiency and giving symptoms of stable angina if it involves coronary arteries, and sometimes acute coronary syndrome as well. Can also cause aortic thrombosis with the distal embolization, and in some cases aortic dissection, rupture. And if it involves upper and lower extremity arteries, then can give give symptoms of claudications and pulse deficits. So first focusing on the non-infectious aortitis, which is a huge entity, involves a lot of pathologies. First, we'll focus on large vessel vasculitis, which consists of giant cell, which is more common, and then Takayasu arteritis. So giant cell arteritis is one of the most common form of vasculitis, accounting for about 75% of cases. And aortic involvement occurs in about 15% of these patients. Giant cell arteritis should be suspected if the individual present over the age of 50, and there's a new onset headache because it has the propensity to involve cranial arteries. and if there are visual disturbances and along with elevated inflammatory markers, there is a criteria for it. So age above 50, new headache, temporal artery abnormality, ESR, and abnormal artery biopsy. If there are three out of these 5 criteria are met, then the diagnosis of giant cell arteritis can be made, but gold standard for this diagnosis remains temporal artery biopsy. So Takayasu arteritis is essentially an idiopathic necrotizing granulomatous large vessel panarteritis disease. It preferentially involves aorta, its proximal branches, like seen in our case, and pulmonary arteries as well. Aneurysmal dilation can be seen in up to 45% of patients, and it essentially involves very young women for 25 to 30 years, and essentially females more than males. Looking at the histology, pathology wise, it shows granulomas and inflammation of aortic.
Oh,
Okay.
5 millimeters. Go ahead.
So, and there's marked infiltration and proliferation of mononuclear cells. So it starts with developing perivascular cuffing in the vasa vasorum in the early stage that over time leads to fibrosis, calcification, and then essentially occlusion of the involved arteries. So certain other diseases that that can give that kind of the vasculitis type present can involve large vessels are Behçet's disease. That Behçet's disease, which usually causes saccular aortic aneurysms, acute insufficiency in association with uveitis and either oral and genital ulceration. Important to note that the vascular issues can be seen in up to 50% of patients with Behçet's disease and involve upper and lower extremities. And aorta is the most common site of aneurysm formation here. There's another entity called Cogan syndrome that's also causes large and medium-sized vasculitis. It essentially gives symptoms of vestibular and ocular symptoms like interstitial keratitis, arteritis, and subconjunctival and conjunctival hemorrhage.
Providing us the diameters.
Certain other rheumatological diseases that can involve, that can present this type of vasculitis is with long-standing ankylosing spondylitis, aortic valvulitis can be seen, and that essentially involves ascending thoracic aorta causing aneurysm. Rheumatoid arthritis vasculitis, and then SLE is a large vessel vasculitis with a similar distribution to Takayasu arteritis. Rarely relapsing polychondritis is essentially recurrent inflammation of cartilaginous tissues. It can be complicated by large vessel involvement with aortitis leading to thoracic and abdominal aortic aneurysms. Another entity is idiopathic aortitis, which essentially means inflammation of aorta, which is discovered incidentally. Retrospectively, after the surgical, most of the aortic aneurysm, its idiopathic aortitis is noted in 3 to 10% of cases. And retrospectively on analysis, most of these cases were related to IgG4 disease. Radiation for any sort of malignancy can involve and give large vessel vasculitis, involve aorta after like decades, but it is limited to irradiated field. And what radiation does is essentially accelerated calcification, as you can see on the CT scan image on the right side. So coming back to the infectious aortitis, since it's relevant to our case because our patient did have a history of tuberculosis in past, the common pathogens causing infectious aortitis involve Treponema pallidum, M. Mycobacterium tuberculosis, Salmonella, Staph, Listeria, Bacteroides fragilis, and Clostridium septicum and Campylobacter. Usually the infectious, it's rare, but the spread of infection to aorta can happen either through hematogenous spread or directly contiguous spread from the adjacent tissues. sometimes traumatic or iatrogenic through procedures. So infectious, usually infected aorta is the part of the spectrum of infectious aortitis. It's infrequent, rare, but documented prevalence ranges anywhere between 0.06 to 2.6%. Just a little bit about syphilitic aortitis. Cardiovascular manifestations usually occur much later after the exposure. And secondary to end arteritis obliterans of vasa vasorum. The disease spectrum, it can cause anywhere from aortitis to aortic aneurysm, aortic valvulitis, aortic regurg, and can involve coronaries, ostia as well. If you want to stop, we can. Okay. All right. Okay. So tuberculous aortitis, it usually does involve the distal aortic arch and descending aorta. It occurs in less than 1% of patients with latent tuberculosis, but it does carry a very high risk of mortality when it does involve aorta. Pathological samples, they show caseous granulomas and multinucleated giant cells and epithelioid cells. So if data involved in when tuberculosis causes infectious aortitis in one study of 39 patients, they noted that 75% of the aneurysms, they appear to originate from aortic wall erosion by contiguous focus, so essentially spread of Mycobacterium tuberculosis from an adjacent tissue to the aorta, and 90% were saccular and false aneurysms, and disseminated tuberculosis was present in almost one half of the cases. Okay. So when it does involve aorta, or in any type of infectious aortitis on CT scan, it will give a presentation of aortic wall thickening. There would be some sort of peri-aortic fluid and soft tissue accumulation, and rapidly progressing saccular aneurysm or pseudoaneurysm, and occasionally, especially in patients infected with Clostridium, we can see occasionally air around the aortic wall. So whenever we're suspecting any kind of aortitis, the initial evaluation, the blood work, I mean the common inflammatory markers like ESR, CRP, have to evaluate CBC because vasculitis can cause thrombocytosis and anemia. So those are some other markers that can point towards it. Assess kidney function, liver function, and blood culture, especially if we are suspecting infection. Which is unlikely but can happen. All rheumatological panel like ANA, ANCA, rheumatoid factor in the appropriate clinical setting. In our patient, ANA was negative, so we did not pursue further rheumatological workup for that. Skin testing, especially if we are suspecting tuberculosis, or serological testing for syphilis. Okay. On imaging, the ultrasound is the first modality to go to. It can show usually like a very thickened internal media, also called Macroni sign. A CTA combined with FDG PET can give some assessment of the active areas. So if the disease is active, it will show up on FDG PET. So like you can see on this image, the CTA, you can see the wall thickening on the most left side, and on the right side is the PET scan only, and that shows that the area of the active disease. Okay, MRA is another modality of choice, and it can also, it's very helpful to assess the active aortitis. It will show wall thickening, and the increased signal with edema and inflammation, they can be recognized, and that will show us, that will tell us about the active aortitis. You can see in the most the down and the right fourth column, you can see there's enhanced ring type looking type lesion that usually tells us that this might be an active disease there. So that's essentially about aortitis. Now, thoracoabdominal aortic aneurysms, they represent essentially the spectrum of the aortitis when the late stages, when the wall has gone through degeneration and becomes aneurysmal. Mostly fusiform, concentric saccular, eccentric saccular thoracoabdominal aneurysms. Crawford classification is used based on the location of thoracoabdominal aneurysms, can anywhere from 1 to 5, and it's important to recognize just because it does affect the choice of our therapy. So degenerative atherosclerotic aneurysm is the most common one, but usually intensity and duration of cigarette smoking is associated with that. Now, inflammatory aneurysm, usually located infrarenal, and again, like we discussed, all kind of Takayasu, large cell vasculitis, and other connective tissue diseases can lead to this. And again, infectious aortitis or infectious mycotic aneurysm usually are saccular, and many strains of bacteria and fungi and same Mycobacterium tuberculosis and syphilis can result in these. Again, it's prevalence anywhere between 5 to 25% associated with smoking. And sometimes IgG4 related systemic disease can mimic this as well. So just the inflammatory idiopathic aortic aneurysm is a little nugget about it is that it does cause periaortitis fibrosis. So it's a soft tissue fibrous collection on the anterior wall of the aorta, and it's important because it does increase surgical mortality. They've reported surgical mortality of up to 23% in aneurysms like these, where there is a periaorta fibrous tissue, and it can involve other surrounding structures like ureters and cause further complications. So, and so there's some connective tissue disorders that are associated with aneurysm, genetically involved Marfan syndrome, Loeys-Dietz, Ehlers-Danlos, and familial abdominal aortic. Usually, risk of rupture is noted 2.2%, with most occurring when the diameter is anywhere 5 to 5.5%. The factors that are associated with high risk of rupture: female sex, large initial diameter, smoking, and high mean blood pressure. A saccular aneurysm morphology is more prone to rupture than fusiform. And on CT scan, if you see a dissection and thrombus, that also increase the risk of rupture. For elective repair, so far the consensus is for men 5.5 centimeters and 5 centimeter for women, or a 12-month growth rate or of equal to or greater than 10 mm in both sexes. And in any, whatever the sizes, if the patients are symptomatic from it, then they should undergo a repair. Okay, now endovascular versus open repair, just a couple slides about it. We have 3 major trials: GOTAG, STARS trial, and VALOR trial. They all showed that good results up to like 30, very little 30-day mortality compared to the open repair. Yeah, so 30-day mortality in all 3 trials was like 2% versus 12%, endovascular versus open, but all that benefit goes away at like 2 to 5 years. So another meta-analysis that kind of showed the same results, but that consisted of like 38 studies involving 6,000 patients. All-cause mortality at 30 days was noted to be lower with TVAR versus open surgery, but there was no difference in stroke, myocardial infarction, or aortic reintervention or mortality beyond 1 year.
Paraplegia was also low.
Paraplegia as
Could
well.
you go
We
2
reduced
slides
it.
behind to show us the endoleak rates that were there? One more. Yeah, right here. Let's comment on the endoleaks.
Yeah, so one year endoleak rate with the GOTAG and the STARS and VALOR trial is like 3.9, 12.2%, which are essentially really low, and very high technical success rate, and freedom from aneurysm related mortality. It's like acceptable at 97 at 3 years, 94% at 5 years, and 97% at 1 year. Okay. So essentially this wraps it up. I mean, this is just stent grafts. I don't think we need to go through these.
I think I think what we're gonna talk about the quick stent.
We're gonna prep it over
that
here.
Was a great presentation.
Amazing.
But before we go forward,
whole lecture really.
I'm gonna have Dr. Dangus go over the IVUS for everybody. So we did an IVUS. Can you show the aortogram first, guys?
Just play again the aortogram. We'll show the screen here. That's great. So just based on the aortogram, the areas of interest are around 5, let's say, the marker. It's around 5. Then, which seems to be maybe some kind of a proximal landing zone when I get measurements there. Then the real lesion between 10 and 11 or 12.
12,
And then
13,
you have
yeah.
a fat patch around 15 or so that we can use for a landing zone in general. And then there is another mild stenosis further down between 17, let's say, that doesn't seem angiographically to be very important. We're going to look at it by IVUS as well. So let's go to the IVUS and to the IVUS screen. Maybe you can keep the angiogram though. Keep the angiogram, just so you don't have to show me. Just keep the angiogram and put the IVUS. This is a gradient still, you can see very high. So let's go up top. This is the very proximal arch, which is a diameter is about 23. Please stop at every bookmark. Yeah, very good. So that's up top. That's about 23. I don't think we'll be involved too much with that,
No.
but that's a very good measurement just to know where we are. Let's keep going further proximally, and then stop right there.
Wow.
Yeah, we're around 12, I would say there, which is in the vicinity of like 5, as I said before. You know, or maybe something like that. It's not an automated pullback, so we have to take the length with a grain of salt.
Yes.
Let's go a little bit further. Keep going. We're entering a tubular lesion, as you see here. Keep coming, keep coming. It's about the same, 11, 12, something like that, the lesion there. Now it starts getting a little lower. Keep coming, keep coming. Now it's getting really tight right here.
Yep.
You see that really tight, and it's going to be right there. Right there, the measurement is like, I'm not sure what is that measurement there.
11.
11, that's pretty generous because you can see there's a cleft of calcium within it. So it's probably between the MLD is probably about, you can take a measurement right there between 2 o'clock and 7 o'clock, please, and see how that diameter is.
Dr. Dangas, you want to comment on the calcification there to see if that would change your plan?
From 2 o'clock, I said, from 2 o'clock, please, to 7 o'clock.
Just a straight line, straight line.
Straight line, yeah.
Yep, that's a little bit, that's good.
Yeah, what's also generous, 10, it's probably 8 because he took it, as you see, from the outside of the calcium. You can come inside this calcium to measure the MLD, right there. 8, exactly as we said, so that's 8. The calcium is really eccentric, and you see it's, you know, it's essentially a long lesion with different clefts of calcium, and clearly those long tubular lesions creating a gradient.
Absolutely.
Because not only is there a focal stenosis, but there is a whole tube that contributes to the resistance of the blood. And the gradient is about 60, as we know, hemodynamically.
ACT?
Come a little bit further down now. Keep coming. So you can see still tubular stenosis. Keep coming. Keep coming. Or stop there.
Oh, okay.
Go a little bit up. A little bit up. A little bit up. A little bit up. Just do a diameter right here. Right there. Between 1 o'clock and 6 o'clock, please.
Probably like 7.
Yeah.
Or so.
Diameter. Let's do one that's really the tightest spot. That's exactly at like 12.
Good. Let's stop.
Fine.
Yeah, right there.
8.
Again, 8.
Probably 6.
All right, interesting. A little bit, maybe a little bit lower than that. It doesn't matter. So that is really, and right afterwards, you see the poststenotic dilatation now. Keep coming. Keep following. Keep following. Keep following. Very good. Stop there now and do a measurement here. So this is the area that pretty much we want to land. And it's all kind of the same. So let's see where we are here. 17. How about the other diameter? Do a perpendicular.
It's probably bigger, yeah.
Between 3 o'clock and 9 o'clock, yeah.
That's fine.
Yeah, that's fine, that's good.
Yeah, that's
So
fine.
you put 18 or 19. So,
Perfect.
yeah.
Well, that's you know, I think, George, that was phenomenal that you went over the IVUS so well. I just want to ask Ajit, and also Raman and Vishal, please, you know, to chime in. Ajit, I mean, in terms of, you know, looking at the angiogram, looking at the stenosis, and we did not go over the CAT scan, right? Do you have the CAT scan with you?
We have 3.
Yeah,
We have
so let's
3
go over the CAT scan
images.
now, guys. Can you put up the CAT scan?
Yeah, one second. Let's go a little bit further down with the IVUS. There's one more point to make is that there was an intermediate, keep coming. There is an intermediate stenosis right there. Stop there, do a measurement here. And you can see this is where there's another stenosis that, you know, we judged before to be mild. And indeed here the diameter is like 15. So indeed there is another stenosis, but not a lot. And I think that's a very important clue in the case, because if we have another stenosis here, we will be obliged to cover all the way down to 20 and then we'll be dangerously close to the celiac. So I think it's fortuitous that this is really not an important lesion.
Absolutely. Can we go over the CAT scan? Let's go over the CAT
Let's
scan.
look at the CAT scan and see, evaluate all these
Absolutely.
lengths by CAT
I don't have the
scan.
entire.
Whatever you have, let's
we have only
show
like
them.
the diameter.
So before while you get the CAT scan up, Ajit, what's the best, imaging modality? I mean, in this particular patient, we don't know the etiology, truthfully.
Yeah.
I mean, he has tuberculosis. He may have a vasculitis. Dr. Dangus sent him to rheumatology. Rheumatology has been treating him, and also Dr. Dangus, the high sensitivity CRP has been dropping, right? Since
So it was 60 a few months back, then it went to 25, and in this admission is around 10.
So
somehow it keeps coming down, which is good. The SED rate was about 45, 50. That came down a little bit. It wasn't. I was actually quite frankly expecting it to be in 3 digits.
Right.
But
Is there any
somehow
immunotherapy, Dr. Dangus?
Steroid or something.
rheumatology is starting the immunotherapy.
Okay.
But they're actually asked them, the rationale has nothing to do with this lesion.
Right.
They think whatever it is now, it's up to vascular medicine and us to decide. They want to give the immunotherapy for any recurrence or any other problems.
Got it.
That
so they feel this is
the
burnt out
patient
at this
would have.
stage.
And
So
one
the
of
other
the sorry, go ahead.
Go ahead.
No, so one of the viewers had a quick question saying, does IVUS help you in the diagnosis, saying the etiology? Because remember, you're doing an IVUS, so does that help you in interpreting where you're going to have your differential diagnosis? Is it more inflammatory, more atherosclerotic, or a combination of both?
Yeah, so first off, thanks Dr. Krishna and Dr. Dangus for inviting me to this interesting case. So in terms of just starting from the imaging that we get, so I think number one is always you need a CTA or an MRA. I think that's just like our other cases here, sizing is everything. So really planning out the case.
Right there.
So this is the CTA here that we can see, and I think that's again, you see the narrowest part in the middle. I think it's a little generous because the actual lumen is probably like 7-8 millimeters. So I think pre-op CAT scan is good for your initial assessments, and then even better is like centerline imaging, and they have software like for 3D reconstructions. But truthfully, I think before you place any stent graft, IVUS is a necessary tool in these cases. We use it often for dissections and aneurysms, but I think real-time imaging, intravascular ultrasound is the best way to get your true measurements, because the CAT scan can be like off by a millimeter or two, which can make a difference.
Well, if we comment on the sizes we see here, in the proximal, we're in agreement. We found 23 by the IVUS, and it's the same. In the tightest lumen, they say 11. And we found 8. Yeah. And in the distal part, they say 22. We found 19 or 18.
Which probably is a little lower than where we measured.
Yeah, it depends where you cut it, right?
I don't know if I think it looks like they measured it a little bit lower than where we are. I think they went below that ambiguous distal lesion that we're avoiding.
Exactly.
So that may be the discrepancy there.
So Ajit, one more question. Now let's talk a little bit. I know that the three of us had long discussions, as did you, with everyone. I mean, the treatment options.
Yeah.
I mean, in this particular lesion, I mean, what is your goal of therapy, and how do you choose as a surgeon the treatment options for this? And I know we had a long discussion with Dr. Dangus. So a couple of questions. I just want to talk about what we talked about. We talked about anything from a balloon angioplasty to a stent graft to a self-expanding stent to a balloon expandable covered stent.
Yeah. So I think there's a lot of potential treatment options, but just to go through that list, so balloon angioplasty I don't think is a good option. These lesions have a high risk of rupture, and if you're not protected after the balloon, that could lead to unnecessary complications and issues. So I don't think that's a good option. Then the other question, which I think is one of the most interesting parts about this case, is balloon expandable versus self-expanding stents. So in breaking that down even further is just bare metal versus covered. So going along with the rupture risk, I think using covered fabric, is the way to go here, because the last thing you want is to deploy your stent and then you rupture, and then you need to urgently place a covered stent. So I don't think bare metal, especially with the technology that we have today, I don't think bare metal is necessarily a good option. I think in the past we've used like wall stents and things like that, but now with the newer stent grafts, I think this is a better option. And then the other thing is balloon expandable versus self-expanding. So, we were talking about this a lot. We're going back and forth between potentially using like a VBX here, which is a balloon expandable stent graft, versus using a self-expanding stent. And I think there's two reasons why we I can think of why in this case, which we're going to go over the stent, but why we chose what we did. So number one is size. So the native aorta here is very large. We're talking about 20, 22 millimeters. So you really need a big graft, and the VBX, you can post dilate to 16, but it's still going to be undersized for the native aorta.
Yeah.
Especially when we're treating, like pressure gradient, flow limiting stenosis, it's important to really get to the native size. And then number two is length. So this is as we can see, there's multiple lesions here. So using a longer stent graft, I think, is needed because we need to treat all the lesions ideally with one stent. And so the VBX, again, I think is coming a little shorter diameter. So
with that, we decided to go with the stent graft.
Yeah.
So before I get to your next question, and Vishal, Raman, bear with me. I've got a lot of questions to ask these guys. George, you saw the eccentric calcium. And why not shockwave? I mean, we use shockwave. I know you do a lot of TAVR.
Yeah.
You've used shockwave in the aorta and the iliac, I'm sure. And Rami and our group has published that data. Would this be something you'd consider for shockwave, considering you have that level of calcium in the aorta and the eccentricity of the calcium?
Yeah, well, that's an interesting consideration. One can say, first of all, the lumen is a bit too big for the shockwave, really, for the iliofemoral circulation and its size there. So I guess the minimal diameter is 8. Perhaps you can try there, but I think the difficult part here and the difficult decision is that aside from this cleft of calcium, there isn't really much thickness in that aortic wall there. So it looks like it's more of a, I would say, self-compressing or shrinking, if you want, lesion there. So it may again be some risk of perforation, I think.
Right. Well, you've done it, and our team has done it, where we've done 2 shockwaves in the distal aorta to get a large TAVR sheath up.
We could.
But there's no reason, I agree.
No obvious reason, and quite frankly, we can, if we have such trouble afterwards, we can have the cover stand, and then you can try to put the shockwave inside.
Right.
The shockwave is going to go through that, and that may be an interesting fact. You have such a problem expanding it. But as we discussed before, and the good part of this case, of the feature of this lesion, is that based on the angio and the IVUS, there is no concern about the descending thoracic aorta near the diaphragm, and there's no vicinity to the celiac. That's very important because it decreases the risk of paraplegia if we don't intervene in that lesion with anything covered. So that gives away, I think, the concern and the possible need for a covered, for an open cell, if you want.
Yeah.
Then the balloon expandable, the risks we said, is kind of not really optimal. So I think the self-expanding is a better technology. And we're ready to accept a small residual there. We're going to do, as we discussed before, a gradient-oriented approach. If we have a residual of maybe, I don't know, 20% or something, and still the gradient has gone away, I don't know we're going to go crazy
I think
with
you
that.
have to be cautious. Can you talk a little bit about infolding of the
Tell us
graft
about that.
and the thrombus and the failure?
Yeah, so another interesting point about this case is that the aorta at its smallest point is very narrow. It's 8 millimeters, and we're putting in a big, sheath, a big stent graft. So the stent that we're going to use is about a 20 French sheath. So we need a big lumen to, number one, to track it. But obviously you're going to have a lot of fabric in that small area, that small aorta, and there's going to be infolding. So I think with that, there's 2 things that, we need to do. Number one is we need to make sure our seal zones are adequate. So we at least have 2 centimeters above and below, which we'll have plenty in this case. So that way we can really crack it open, with the balloon after if needed. And then number 2, we have to make sure that the lumen is big enough so our stent will track and at least expand a little bit. So
you can get out the delivery system.
Exactly. So that's a real consideration, and it's hard to gauge. But I think with at least a 8-9 millimeter lumen, we'll
should be fine.
We'll be okay.
So Jit, one last question. You saw what Twinkle presented, the different types of graphs. You and Dr. Dangus and I chose a cook. So the question is, why one graph versus the other? You saw that the data is pretty equivalent. Spinal cord ischemia maybe a little higher, a little lower. We'll talk a little bit about that. But why did you choose this graph?
Yeah, so a couple of reasons. Number one, I wanted a small stent graft.
Can you guys show over here, please?
We can take a look here. I don't know if they can see.
Well, let's
You know,
zoom. Yeah,
yep,
they're
they're
going to
gonna
zoom
zoom
in.
in. They're gonna zoom in.
Yeah, so this is the delivery system. So this cook device, it comes in the, obviously the delivery system, and it also has its own sheath that you can leave in afterwards. The advantage for this, I think there's a couple of reasons. Number one is it's a smaller stent graft, so it's a 22 millimeter. A lot of the stent grafts that we use for the thoracic aorta are bigger than that. So because the native aorta is, it's not an aneurysm that we're treating here, the size was good. Number two is this is actually a dissection stent. So what that means is that it doesn't have bare metal proximal to the graft. And the reason that's good is, the last thing we want is a retrograde dissection.
Exactly.
We don't want bare metal pushing against the aorta.
Mhm.
So this one doesn't have that, which I think decreases our risk of a
I
retrograde.
think that's an important point.
Yeah, issues proximally.
Yeah.
And the other nice thing about this is it's stainless steel. So some of the devices that we use, a lot of them actually are nitinol, but stainless steel gives you more support. And so especially since we're trying to have a stent that's really pushing against that stenotic area, I think this is going to have more radial force to really open up in that narrow area.
That's very important. The
Yeah.
radial force here is very important because
Definitely.
we can imagine some of the others you deliver it and then it kind of
Collapses.
narrows and then you end up having put something
balloon,
stronger
right.
Inside it.
So I think that's an important technical feature. We've seen that even in other areas also in the, let's say in the arterial bifurcations
course.
and all that. You put some stents that they look good for a moment
And then they
and
collapse.
then they shrink down in the due to the recoil and this is good to avoid so much of a
Yep.
recoil. Let's see how
Yeah.
it performs though.
Can you tell me about the prep?
Oh yeah, Stephanie, you want to come
Yep.
on here?
Yep. So we're
So
gonna
what's-
go over the prep here very quickly.
All right, so just
So remove the stylet.
yep. So there's a stylet at the end that we pull out, and then it takes.
Go ahead. Let them show. Mhm. So it's a breakaway sheath, everyone,
yeah.
right here.
Just
So we're gonna pull the breakaway sheath apart.
more or good?
So like the peel away sheath, you're just pulling it
Yeah.
off. Okay.
That's
Peel
it.
away
Excuse
sheet
me.
off.
There's a white cap on the end, so hold the green and pull back on the white.
No, no,
No,
no.
no, no. This.
1 second. I think
Beautiful.
Dr. Dangus is in front.
Dr. Dangus, you have to
can't
move
see
your hand.
anything.
Okay,
Yeah.
why don't you do
So
it?
why don't
yeah,
you come
so
PK
can do-
side? Yeah.
Yeah.
Thank you.
Yeah, so it's just flushing the end of the stent,
So-
the device right here,
Yeah, so flush the end lumen
and
essentially.
then
Yeah.
finally there's this port.
Mhm.
Yeah.
Yep. Stop cock. Right here.
Okay.
This one.
Flush.
Oh, down here?
This
Yeah.
one. Okay. So guys, I mean, just to review, Dr. Dangus broke away. Show Twinkle that little piece, the little white piece right there.
It's
Yeah.
just really a cover.
Yeah,
You just
just
pull
a
it
cover.
out.
And, yeah, and so this is flushing
fills
the
this thing also
sheet.
here.
Yeah, and so
Skip a little bit more.
Yeah, I know, but it's
and then the last thing to show. So this is the sheet. This is what we're gonna leave inside. This is the end of it here. This is the actual delivery system that's gonna get deployed. This is
that's
so this is a pin and pull device. So when you'll see it, but when we start deploying it, we actually unsheath it this way, push it back. And then finally to release it off the delivery system, it's a trigger wire here. So after we deploy it, we pull this out.
Good. Okay.
So that's how this one gets delivered.
okay.
Yeah.
Good.
Why don't you show that? If you push a little bit out, you can see you need this to go to the nose of the graft, please. Don't show there. Go to the nose of the graft right here.
Yeah, the nose. Perfect.
The other
All right.
end of the tape.
The other end,
There
yeah.
it
Yeah.
is.
Yeah. You can see now. You really want to keep flushing until there's some dripping out there. Okay. You can see there's some.
Yeah.
The drops just came out here now. We put about 30 or 40 cc's through
Yeah,
this in order
yeah.
to really flush it all the way. That's it.
Okay. A couple of other points, Ajit. Anything else you need to make about on how you're going to deploy this?
No, I think we'll show the
Not the
images,
twist wire.
but we just got to make sure we have at least 2 centimeters below the stenosis, so that way we have good seal when we
All right.
balloon.
A little bit of shop talk before we do it is one, Dr. Dangus just pointed out, we have a Lunderquist wire for support. We have 2 12 French sheets across, and we're going to change out the one on the right.
Right.
We did the IVUS through the one on the right on the Lunderquist wire, and on the left we have
Right.
a pigtail there at the stage, and we have the ability of an aortic occlusion balloon in case we rupture the aorta to go ahead and in. So all this preparation has been done. We've done dual per closes. We're doing this on heparin, Vishal and Raman. We're doing it on heparin. ACT is $299. We have plenty of ACT, plenty of heparin on board, and we're just going to go ahead and deploy. The key is, if you could show the screen, guys, for me. Show the screen. So the key is you can see that Dr. Rao has marked the screen. Actually, you can't see at the level of the of where he wants to land the graft.
Around
Yeah,
15,
around
essentially.
15. That's
So yep. So
15
so
about three.
he's got it. He's
We
got it
have
ready.
frozen the table and camera.
Exactly.
So table and camera are not moving, and we're going to do an over-the-wire exchange.
Exactly. But
Okay.
one last question, and I know the audience has this. Comment on the incidence of spinal cord ischemia and what are the things that increase the
Yeah.
risk and don't increase it, because I know that was one of the things that Dr. Dangus and I
Sure.
and you talked about.
Yeah, so definitely. So I think in this case, we're very low risk for having any sort of spinal cord ischemia because we're using a short graft. So we're using a 12 centimeter graft. So typically one risk factor is if we use over 20 centimeters. You know, commonly we think about that for dissections and things like that. So we're not doing that. The other important thing is the collaterals to the spine. So in this case, you know, we're not going near the subclavian.
It's occluded anyway.
Yeah, the iliacs are, you know, open, the hypogastrics. So I think in this case, you know, because we don't really have any major risk factors, the chances of spinal cord ischemia are low.
And also, I think what Dr. Dangus pointed out, that you're going to stay above the celiac is huge.
Way above.
You know,
Yeah.
we're going to be way above it. We're greater than 5 above it. I think we're going to be
Exactly.
fine.
Exactly.
Okay.
Yeah.
And the choice of graft, you did, other than those, have you had experience with any other grafts?
Yeah. So for these core, you know, these aortic stenosis in the thoracic aorta, I would say the most commonly used stent grafts I see besides Cook are the Gore has a tag device that's sometimes used. Again, for the same reason, it's a low profile, tracks well, and it's easy to deploy. So that's another one that sometimes gets used. And then the VBX, I think balloon expandable stents. VBX.
Perfect. All right.
So,
So let's do it.
Alright.
So we're going to walk out the sheet now. Dr. Rao and Dr. Dangus are going to walk out the sheet with the Lundquist wire. And I'm going to get the device.
All right, get a device. The sheet is out. It was a short 10 cm 12 French sheath.
So we're going to keep the device straight.
Ajay, does this, are we able to retract this device back and replace it to a certain extent, or once you start unsheathing it, it's a point of no
That's a
return?
good question.
yeah, that's a great question. So in this case, the most important part is the initial deployment.
Okay, Flora
So
does.
the first couple of stents that we deploy, the first
Okay,
one
we're
or
in
two,
safely.
that's our
I'm ready.
chance to really reposition it if we need to.
Don't move the
Af-
table. I got it.
After that, you know, it's kind of going to be fixed proximally. So the chance to reposition it is really in the beginning when we deploy. But in terms of like recapturing mechanisms like the Gore excluder or something like that, where you can kind of collapse the graft, that's a pretty, yeah, that's
PK, did you
unique to Gore.
pre-dilate this lesion?
No,
or
we did not. We
No,
talked
we-
And the
about it.
reason? Yeah.
The reason
Can
is
we
we felt that
just pull that wire?
the device had
it.
enough
What is weight?
what is it called, a profile to get through.
And then I just
Oh,
need to
okay.
bring it up more.
Whenever you're ready.
So can we see the,
The pigtail's still there.
and then we can see the screen on the live?
Yeah, of course.
Yeah, we
Yeah,
can.
so-
Yeah, we can see it.
So looking here now, you can see the top of the fabric is those
It's gonna
dots. So right now it's around like 1 centimeter.
Yep.
Now, does it shrink from above or does it shrink from below is a question. So some of those,
That's a
when
very
they
good point, yeah.
when they open up, they decrease in length. You can see now it's 12, looks like more than 14 here. But does it go down from the top, does it go down from the bottom, or does it go down from both directions?
Yeah. So
Four
I think
inches,
this,
yeah.
so yeah, I think the stent's gonna,
It's gonna
this
be
is a
fine.
good stent graft. I think it's gonna stay in place. And then the bottom is really what I think we're gonna focus on when we deploy, because we need to really nail it, because we're only a
Right.
couple centimeters away. So
Yeah.
the
So-
bottom of the stent graft is
Go
around
ahead and
15.
just show us how it's done. Do you want some dye from above
Yeah,
or anything?
let's just do one more picture
Okay,
just to
DSA,
be.
ready?
Sorry, do you mind if I
Ready to
just
Cine?
get a little more comfortable?
You're good.
We are, yeah, we're ready
Everything
to
is
see
set.
it if you
Yep,
want.
Cine? Oh, wait, he's moving.
Don't move.
Let's go because we're
Okay,
occlusive
hold
in
on,
the
hold on,
aorta.
hold on. No. Recluding the aorta, he's having
Okay.
abdominal pain.
Okay.
Yeah.
Yeah, I think it looks good.
All right, I'm
The
gonna
proximal
deploy.
end of the stent.
Relax, guys, everything is good.
It's good.
He's going to be fine if he throws. I know.
Like,
That's
move
fine.
the little bit.
I'm gonna deploy.
No
Right?
problem.
Deploy.
Go ahead.
Take your time, no rush.
Say something, Stephanie. Were you? Okay.
Looks
Keep
really
going.
good.
That's the first coming up now,
Yeah.
right?
There it is.
Keep going. Keep going.
Bada bing, bada
Okay,
boom.
we're a little bit higher than 40. Oh, you came out perfect.
Yeah, perfect.
Yeah,
Perfect.
we're
All right,
15.
All right,
let's
let me
remove
walk
this to.
Up,
Trigger wires.
Yeah.
fluoro.
All right, got several more steps to kind of safely remove this.
Pigtail is trapped.
Yeah, that's fine.
It's okay.
So we're going to now
Please.
recapture.
Blood pressure control, please.
Okay. So now we're basically Good. Pulling out the other wire.
Yep. So these are the trigger wires we're talking about.
Mm-hmm. Now we're gonna.
So now you can walk it out, right?
Okay, ready? The gray. Mm-hmm.
And walk it out, right?
So you said
All
the
right.
sheet stays in and this introducer comes out, correct?
Yeah. And
Yeah.
let's get the balloon ready. The 14.
Oh, it's stuck on the graft.
Okay, let me take a feel. Can someone hold the sheet?
Someone hold the sheet.
And
You
fluoro.
may be also stuck with it because of the pigtail.
Pigtail.
Yeah.
And that creates another.
Seems to be yanking the whole system down. I think it's really at that most
Is there any
tightest
other
lesion.
tricks you have here?
Why don't you push the sheet up?
Mm-hmm. And sheath it, exactly.
Let's go there.
It's almost out.
Okay, I'm holding the sheet up.
Okay.
Advance it.
Advance it. Sorry, can I?
All right.
There you go. You got it.
There you go.
Now just walk it out.
Now walk it out.
Hold the sheet, George.
Still hold the sheet there. There we go.
There you go.
Okay,
Good.
came out.
Good.
Very good. Stop
Very
there.
good.
Okay.
Where's your sheet?
Out.
Your sheet is out?
Well, it's not
No,
out
it's not
fully.
out. Yeah. Good.
All right, let's
It's
get the
just
balloon.
below in the air. Yeah?
Let's get the balloon, guys.
Hold the sheet
Yeah,
here so it doesn't
balloon
come
is
out.
I got it.
We're gonna have to take this out though because it's too far back now. Do
All
we
right.
have that 20 French sheath?
20 French sheet, guys.
No, it's right
Well,
there.
it's not that
You can
much out. I think
introduce-
we're
yeah,
good,
yeah,
guys.
yeah,
We're
yeah.
good.
But I don't know
We're
if
good.
the
Let's
balloon
not
is
make
long
this
enough,
more
though.
complicated in
We'll
this.
try.
Oh, the balloon shaft.
It should be long enough because
Okay.
that is
Okay. You have the sheet,
holding
right?
this.
Let's see
I'm
the sheet.
holding this.
And we need to advance the sheet. Advance the sheet. Advance.
All right.
There you
Good.
go.
All
That's
right,
perfect.
perfect.
Now hold it there.
Okay.
Now just
Holding
walk this
here.
out. I'm holding the sheet. Don't worry.
Yeah, good.
Very good. Everything is out now. Good. All right,
All
that's
right.
the balloon, guys.
Here.
You walk this out for me.
I got the sheet. Don't worry, Jet. I got the sheet.
Beautiful.
Yeah, for those at home and everybody watching this case,
Flora,
I mean,
please.
Flora,
Blood
please.
pressure
Flora,
control.
please.
important things is
Blood pressure
is
control.
all
Flora?
the
I don't know where
You know,
some fluoro.
constant
Yeah,
hemodynamic
better.
monitoring and
Keep
case
going.
planning is
Yeah, can you just
beyond
help me?
imperative
I
here.
am.
You know, just watching this entire aortic
Wire?
graft
Just the wire?
move is something that is
Mhm.
you know concerning
wire
to,
up,
to
wire up,
wire up.
watch. But I think it's very
It's really
important to really
Wire up.
prioritize
Yeah.
case
We
planning.
can
here.
rewrite. I think we're
I
gonna have to
completely
Okay, don't
agree
worry.
with Raman. I mean, again, it's a multi-specialty, multi-modality intervention.
there?
So
Don't worry.
just
Wire
can't
is
do it
very
ad
tight.
hoc once.
Yeah.
And of course, have your partners, the vascular surgeons,
Yeah.
Do we have
Put
a-
the wire in place.
do we have a
put the
super
wire
to
on
really
over
have
the wire.
these extra brain and extra eyes right there in case things
Yeah.
happen. It might sound easy, stent graft, pin, pull out, but
the
like
left?
you saw, things can happen, and there's always ways to go around it. But that was a good technique to show.
Yeah.
The placement was very well
Resheathing
placed.
the
yeah,
Put the catheter on
cells.
top of this,
Exactly.
please.
Yep.
Yeah.
This wire is a little.
Still
Put the
not
catheter on top of
entirely
this.
out
Give us
yet.
the end hole catheter for French, please.
the-
Yeah, give
the
us
length
hole catheter.
It's just stuck to
For
the wire.
French and hole catheter.
You know what? We need to pull the wire out. Is
Yeah.
that okay?
Yeah, that's fine.
Yeah.
Our sheet is
Give
up
us
there.
a super core wire,
This
guys.
is 4 French.
Give
Super
us
core
the
is here.
super core and the end hole
Cheater.
catheter we had.
Give me a
and the
cheater.
end hole catheter.
Give me
Now,
a vertip
while-
catheter.
A vertip,
Because while
we
they
have
try
it right
to
there.
rewire and all this stuff, another question for you, Vishal. Would you have given,
We
you know,
need cheetah.
obviously
Yeah, here.
hindsight is 20/20 now,
Put
but
this thing.
what
Put the
would have
catheter
been
through
your
this, through the.
ideas about maybe
Put the wire through
pre-dilating
the catheter, please.
this
Yeah.
was the same lesion? Because this is where it
Is it
seemed
gonna
where
go
it
in?
was actually stuck.
I think it's again
there
a
a
good
hole?
thought process. The lesion was definitely tight and very concentric, and like we were discussing,
Use
like
it.
as PK, did we
This is
pre-dilate?
better.
You could have gone both ways, like
There
you
you go.
said. Sometimes, if it's aneurysmal, then of course you don't really pre-dilate because we're used to not pre-dilating
pressure
and just
control,
deploying the
please.
graft. In this case,
Laura?
it's more of a stenosis. So maybe, yeah, in hindsight, a pre-dilatation would have
We have that
helped.
balloon. Grab the 14.
But because like you could see, there's eccentric
diagram.
calcification with
Yeah.
a very stenotic lesion,
Very
and because
tight. There you
even
go.
though
Entirely
it's a
exclusive with
hydrophilic
just,
sheath,
Yeah, through.
correct.
Exclusive with
There,
just the
you could
sheath.
still have issues
This
going
one has
up
a
and
diagram.
down. So I think
Yeah.
that's what, and with the
Yeah.
pigtail being there, probably took an extra lumen, even though
put
you can
back
say
the
it's a
lander
4 or
push?
5 French pigtail, which is
No,
not
you'll be fine with
2.3
this.
millimeters,
Yeah.
but still,
What
it
do
took
we-
that
what
extra
do we-
space
well,
out, which was
you put
required
the-
enough
Oh,
to
no, no.
slide the
Yeah.
sheet back and forth.
Yeah.
So
Yeah,
I
so-
think that was also one of the factors. But yeah, I mean,
And also having like
Yeah,
the
so-
proximal
Interestingly,
distal
when the
landing
catheter
sills.
was delivered, when
Flora.
the sheath was delivered, then there was some occlusion obviously there. He had a
Yeah.
lot of abdominal discomfort.
right.
Makes complete
Well,
sense.
It
yeah,
just
of course.
shows how
expected.
significant the lesion
Yeah.
was.
Yeah.
That's all. I mean, that's why we have great nursing. We got Elizabeth
right.
in there too. I
So
mean,
yeah, I mean, me and Raman were also talking about,
What
like
is it?
PK mentioned about
Keep
the
going. You're coming up now.
spinal
Spinal, there it is.
complications.
Come up a little bit more.
So for the team, do you maintain a certain
up.
blood pressure to make sure there is spinal
The balloon
perfusion?
is down here.
You have certain
Come on,
cutoffs?
yeah, I'm going up. What's
I
that,
guess
buddy?
they're no, me and Raman were
Okay,
talking
good.
about how spinal complications and
Do you want me to pull out
paraplegia
the pigtail or
happen.
no?
Well, a little bit down.
I am
I
gonna
guess
pull
I'll
it
let
down.
them work
Yep.
right now. So yeah, it's
Yeah.
a
I don't know.
let
Okay,
them
that's perfect.
stabilize,
Where
get
we
the
are.
wire in.
Unless you want to pull it and re-enter.
Pigtail is good.
Yeah, let's just balloon it first.
Okay, I'm just gonna go a little lateral just to see.
Yeah, so one of the techniques
Yeah.
that you do in aneurysm is getting back into the lumen is probably just take a bigger wire, loop it, and just make
Exactly.
sure
Swirl your
this is
catheter
a,
around.
oops, sorry. No, you're gonna get more and more dye. This is 16 balloon
Where's the
guys we
dye?
have across this lesion,
Yeah.
and we're just
You
gonna
can
go
see
up.
it
And like
here
I said,
again, right at the
we
tightest
have a
spot.
covered stent
Correct.
graft. We need to expand it, and that's what we're doing.
Have another super
Okay, do you plan to get the pigtail out before you expand it, because
Jump
or
forward.
you
No,
still
come
want
forward.
are
That's it.
okay with
Just go.
gelling it behind the graft?
We're okay with gelling it right now.
Okay.
Yeah.
Mm-hmm.
Yeah, I mean, this is,
Be
we have to
easy
do
enough
this
pull
when
it out
we
afterwards.
fix a lot of aneurysms.
So
balloon up a little bit more. It's okay.
The pigtail
Should be
does,
good.
Down a little bit.
yeah,
Let's
always
balloon
ends up
here,
on
the one
outside.
balloon
Good.
here,
It's
yeah.
outside.
Right.
No,
I
no,
mean, that's
you're-
how, right, exactly. I mean,
Blood
aneurysms, you have
pressure
enough
control.
space and coverage and a lot of gaps sometimes,
whatever.
unless, except for
Well,
the
yeah,
end
We have
seal
Leviplex.
zones.
Mhm.
But this case is more
You don't have
stenotic, so
one?
it's just
Can
a
you
little bit
get it from the
reverse.
pharmacy?
And you can see here on the screen now that the stent's opening up with the, so.
How high are we going as far as the
Nominal.
ATMs?
Right now we're still low. We're only at
That's-
We have
4.
that's nominal.
We have an
Yeah,
aortic
he's gonna
occlusion
feel
here,
this.
please. Let's
Pain
release
again.
it.
Wow.
Yeah.
Let's release the aortic occlusion.
Okay. I'm gonna set that
Release
down
it.
for now. Can we get rid of the pigtail now?
Yep.
Okay, before we give me the,
Get a wire, please.
give me the super core, please.
Oh, we're using it over here. Do we have
Super
another
core.
one?
Give me another super core.
So now you're gonna lose the aortic pressure up top, Liz.
Go lower mic, please.
We just
Go
want
ahead, brother.
Yeah, so we planned that this would potentially happen, which is why we had a 14 balloon open ready to post-dilate this
please.
graft.
Mhm.
Because, you know, since this isn't a balloon expandable, we don't have
Very
that
good.
high
Very
pressure
good.
initially
the
when
wire
we're
up.
deploying the graft.
Good. Now we have the wire up, and we're gonna walk the pigtail out. All right, I'm gonna move this balloon up a little bit
Why do you
now.
want to walk the pigtail out?
Yeah, because you already got the pigtail out, right?
No,
the
he's
pigtail,
going to
I'm gonna
replace
put
it to
through
the main
lumen.
lumen. Yeah.
No, we're gonna balloon though.
So what?
We're not
Keep
gonna
balloon.
balloon. You want to balloon with the pigtail in
Yeah,
place?
yeah, keep safe for
The pigtail is inside the stent now? Or
Yeah.
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 Pigtail is inside the stand, yeah.
Oh, yeah. No, I wouldn't do that, George. Take it out.
Why
yeah.
not?
I wouldn't do that because I think you may actually rupture the fabric. So take the pigtail out, and we can always rewire it without a problem.
Okay.
Yeah, just pull it below.
1 second. Let's
Yeah, pull it
He
below.
wants to take a picture.
No, I think you're fine. Floral?
Yeah.
Floral, please.
Fluoroductive?
Yeah, I think you don't want the pigtail to be in there because you could rupture the fabric. So bring it out.
Yeah, it's better
Yeah,
wall
bring
out
it out.
position.
Just
so,
take it out, and then
Right.
yeah, we can
and
always
the,
go
the
back
lumen's
up.
already
Yeah.
opened up a
alright.
little bit.
So let's
we'll
go
be
up
open.
now. I'm going to move
Just
it
out
up
of
a little
curiosity,
bit.
that was attached to pressure. How is our
The
gradient
pressures are
looking so
still
far?
there's still a significant gradient.
I
Yeah, I'm
have
sure.
need to tell
Oh,
you
just-
that the
The balloon's coming back a little
Okay,
tiny bit.
down.
no,
Balloon's going up now. Okay, go up now.
Yep, hold it right there. What's nominal on this balloon?
4.
4.
4.
Okay,
Rated burst 7.
got it. So I'm going to take it. Now that we're protected with a covered stent, we can be a tiny bit more aggressive.
Okay, actually, we need to put on coronary, please. Down.
down.
Coronary, please. See how much significant recoil there is, Flora?
Yeah.
So the question is, do we need to go with a balloon expandable stent inside?
You want to go?
Or-
The shockwave is inside.
Well,
let's-
let's-
Yeah.
We should take a picture after
yeah, we'll
this,
take a picture.
see what's
Let's
going
see what the
on here.
gradients are.
You can also iris.
Yeah, because I still haven't been
Iris
very
for what?
aggressive
They don't wanna
with
do
the
iris.
pressures on this, so we could take it up. We could use a 16 balloon.
Pressure's 88
Yeah, I think
now.
probably a bigger, slightly bigger balloon might give you enough for like a little bit more time.
Yeah. Calm down.
I mean, the balloon
Calm
expands
down.
well.
Calm down. We cannot occlude the aorta so many times.
That's okay, guys. We have, I mean,
We gotta-
we got to either expand it or not do it, you know?
No, I'm saying we can do
Yeah.
it, but with multiple. Come a little bit back
Inflation.
with this balloon. Come a little bit back.
But
Yeah,
we
maybe
need to-
center it. Yeah.
We need to tack the proximal edge too, guys.
No, this is higher pressure.
No, we can go to oh wait,
Alright.
let me go into the aorta
Yeah.
now. Hold on.
I want to take a picture.
Yeah, we'll take a
So-
picture. We'll take the pigtail up after this. Cycle of cuff, guys. 8, 10, 12. There you go. Now you got it.
Are you in
Now
coronary?
Now you got it. Yep.
All right,
Now
let's
we're
take
gonna
a
now we're gonna
picture.
push the pigtail through the stent, Flora.
1 second.
I'm just gonna walk the balloon back. I'm gonna fix the sheath. Go.
You
go.
got my sheet?
Yep. Let it come down. Okay. Now go the pigtail up.
Okay, I'll
Good.
let it-
It's not going.
I need a wire.
We need a wire. Get a
Give
wire,
us
please.
a super core.
So there's still a very significant gradient, guys.
So yeah, so right now we're using a 14 balloon. So the other thing to consider, we'll take a picture, is to go up with a 16. Because I would say most of the stent graft has opened up. It's that one area.
It's
That,
that same lesion.
yeah.
No, we'll open it.
Do you
Don't
have
worry.
any pressure on the sheath? Does that cook
We-
sheath have a pressure line to it? by
We
any
do
chance?
have a pressure on the sheet.
Yeah,
The-
yeah,
the,
don't
the
worry.
sheet
We have
pressure
everything for you.
is
Just don't get an
121.
idea.
It's 121 right now.
Okay, good. So some improvement for sure, but not still there.
Mm-hmm.
Yeah, just an
Okay.
indirect marker to see how it's behaving. But yeah, I'm sure you're going to IVUS as
16.
The
well.
pressure now gradient is about 20 to 30.
16
20.
balloon. 16.
So improved. Very
16
good.
or 60 or something.
So, press
We have
inject. On the right, yeah, and then press OK.
Did you get one from the OR or?
And press OK.
All right, 1 second. Let's do a little. Can you
the
zero the
Dorados.
transducers, please?
The Armadas, the 16 Armada.
You don't have 16?
Oh, really? I thought we had. Oh, open up an XXL balloon. Then.
Zero both transducers, please. All right, very good.
All right.
So
Okay, let's take a picture. Okay, well, hold on. He's
The
moving.
pressure is about 30. That's good.
Hold on. Okay, hold on. Now tell him not to move. Hold on, I can just make it lower mag.
Or
Hold
do you
on.
have it, please, the DSA?
Yeah, she's on DSA.
DS
Laura.
I want
No, it's on
DSA?
coronary. It's on
We'll
coronary.
put it on
hold
DSA now.
Yeah.
No, actually,
On
yeah.
DSA now.
All right, ready?
16.
All right.
Any?
Ready, DSA?
Wait, please.
Is it?
It's on DSA, yes.
Okay.
All right, don't breathe, don't move now, sir. Don't breathe,
We
don't
have to
move.
balloon it.
now, yeah.
Go.
All right, good.
We got to balloon it. Okay. Give us a XXL.
Good. First
So-
of all, there is no, there is a very good seal up top. There is no,
Yeah,
there's
but I
no
mean-
sign of perforation or dissection at the edges.
Yeah. I mean, you
The
would.
distal
Huh?
seal is very good.
No, everything looks really good. But what I'm saying is, I think in this case, you have to balloon because your gradient is still quite significant. I would at least balloon one more time. It may be a 10 millimeter gradient.
Let's
You
balloon
stop.
up top as well.
Yeah, of course, you got to get the seal. Yep.
Nominal and all.
But I think our deployment was
Perfect.
spot on, you know?
Perfect.
All
We
right,
have
let's just
nice
hold
seal
here.
distally.
Exchanges.
No,
All right.
fine.
And
So
the
you
other
need
good
to-
thing
no,
is
you need
now
this.
we can be more
Exchange is better
aggressive
now.
because
Yeah. You got the sheet?
we're,
Yeah.
you know, the whole stent
Ready? Thank you.
covers the lesion.
Laura,
So we're,
just
we're
Laura,
protected in that sense.
Laura, for me, please.
So we just tried a 14 millimeter balloon, which didn't, a high pressure balloon. So now we're going to try a 16.
Okay, walk this out, guys.
So we're all working through this cook sheet, the stent sheet, correct?
Yeah.
Everything is
Right.
inside that lumen now.
Beautiful.
So listen, for the audience at home, okay. So a couple of things. I mean, you saw.
need-
We need the XXL.
You-
What balloon we have now? What
Okay.
size balloon?
It goes through that one now.
Too
It's
short.
a short shaft. So we've got to change the sheet out.
Why?
So give us a 20 French sheet, please,
Why do we need that?
because it's short shaft. An XXL.
Okay.
So we got to come this out.
Oh, we
Give
have
us
it,
a
right?
short sheet.
Is it ready?
That-
Dilator's that right over by your hand right there. Yeah.
That's fine. This is a 20, right?
We need a 20 though. We need a 20.
Oh, do we have a 20? Can you check back there? We have,
We don't have 22, or we have 22.
we have a 22. I'm just seeing if they have a 20. 'cause
Yeah.
that-
Why go bigger?
Yeah, but if not, we can use the 22.
So guys, I think it's very important. I think the abdominal ischemia that you had is going to occur. He has a very, very symptomatic stenosis because he was extremely symptomatic when walking. When we put the stent graft in, we essentially, as you saw by the picture, can you show the screen, guys? When you saw the picture that we took with the stent graft there, you saw with the stent graft across, it was
There's no
completely
flow.
occlused. You see that? So
Yeah.
essentially, he had mesenteric ischemia. Automatically,
Still
he
too
started
long.
getting
All right,
nauseous.
22.
And because he was getting nauseous, that's where you need good nursing. So this is very important because obviously in these kind of lesions, when you're open, meaning when your patient is awake and you're doing it with a patient who's awake, you actually have the luxury of knowing how symptomatic the patient is. So it's very, very important for you to discuss that with your nursing staff, especially when it occurs. So now we have the sheet here.
I don't know.
That's not it. Yeah, that's not it. So they opened the wrong sheet, which is fine.
So now you're
and-
going to go with the 16 millimeter balloon or 18?
Yeah, I mean, honestly, the gradient is not bad, but I'd like to get it to at least 10 millimeters. I mean,
Sure.
Yeah.
For
if you
big
Yeah,
vessels.
that's great because also as resting gradient, we're going to really get it. If it's in the
Gonna
range
cut
of
that
10
shit
to
out of there.
15, I'm very happy.
Right.
Okay.
Well,
So
you know,
let's predefine that is we reach under, we drop the gradient under 20, we're very happy.
well, you know, actually, George, I mean, you are protected here with the stent graft. I'm not saying that you need to go to zero,
Absolutely.
but I'm saying that, you know, what we could do is, you know, remember that if it's 10 at rest, when he ambulates, you may actually, it may become worse because of vasodilatation. So what I think we should do here is we need to balloon with the 16, reassess the gradient, and then as a group decide whether we're going to stop or not. Honestly, usually a 12 millimeter balloon is all you need to reduce the gradient.
Yeah.
I'm very surprised here that with a 16 we couldn't reduce it.
What do you think about the double shock waves now?
But that's what I was worried about the calcium. You know, we talked a
Yeah.
little bit about that.
Yeah.
So we will take that.
I think it's just you know, the aorta has just kind of atrophied a little bit because the calcium's not circumferential, so I wouldn't imagine that it would hold up our stent.
All right,
Just a
we're going to
small
walk
aorta.
this out. Watch the pre-close, please, Flora, whenever you're ready.
I guess
gonna
one
keep-
important step, Ajit, is like, what about the seal at the top? Remember the top, it was like 22.
We're good.
And,
No, the 22 is way up where where there's
Right.
at the very first
At the beginning of the...
very first marker of the pigtail. We weren't gonna go that high anyhow, so we still somewhere where we wanted, and there still needs to be a little, dilation up there.
Yeah, so I think seal-wise, approximately, we just had that one lesion around 12 or 13, but
Right.
we have centimeters of stent
Excellent.
graft above it.
Okay,
So-
so we got the sheath up now, and now we're going to go with the actual wire. We are on a supercore, not a Lunderquist, so it's always worrisome when you're using large devices on a supercore, but it is quite good.
Yeah.
But we're going to now go with the XXL balloon, and we're going to pull the pigtail back and balloon it again.
Yeah. Another thing that we didn't discuss, but is important in all these cases,
ACT, Ray?
is access vessels. So in this case, this patient had healthy 8-9 millimeter, at least common femoral arteries. So you can accommodate these large sheets. That's one less thing to worry about.
Yeah,
Pull.
that is so true.
Pull to me. Flora?
All right.
So, Ray, do you want to go to room 4? Just until
Let's see how it goes now. The good thing is that the sheath took us all the way to nearly the celiac artery above the renals. That's good. So we have a lot of support for our equipment, and we have a shorter
we
balloon.
start
Let's
here.
go up top.
I'm going to just bring the
We're gonna
balloon,
go high
I'll
up.
just bring the pigtail back. Okay, very good. We'll start here.
All the way up.
Wire up, please.
Let's go all the way up. Go to the. We never
Well, you-
dilate.
you're
Now
gonna
let's
have-
start
you-
from the proximal and just keep balloon the whole thing.
Yeah. Try a little
You're
bit
going to
more.
have a shoulder, guys. That's
A little
why.
bit more proximal.
Yeah.
You're going to have a shoulder.
better
so you
to
don't-
stay
yeah,
within the
it's better to
fabric
stay
here.
within the stent.
Because there's no issues up
There's
top,
no
you know?
issues. Yeah, we got a seal up top. All right, let's go up.
Up. Come a little bit up.
Oh.
Go up a little bit. I mean, push it in a little bit.
That's good. The shoulders
bit
is
more.
what I'm
There's a
worried about.
shoulder there.
Yeah.
The shoulder is going to be quite big in this balloon. It's an XXL balloon, so. See, and you can see the shoulders, guys. Everybody at home, you see the shoulders, how it's almost out of the
Yeah.
stent. What's nominal here?
Just
Well, I'm at 2, so we have a long ways to
Five.
go.
I think
You-
that's
you
plenty.
feel
That's
it
plenty.
there. Oh,
Down.
yeah.
Yep.
Wow, you can see it feels all the leg.
No. He does not like that sensation.
Yeah.
I'm going to walk
Wait,
it back.
wait. It's not
Let it
down
come
yet.
down.
Of course.
All
So-
right.
I think you can, in terms of the anesthesia, that's kind of another consideration. I think in this case, it's nice to do it awake because when we deployed that stent, for example, we knew exactly that we were occlusive. And if he was
Down.
totally asleep, we may
Down,
not have
I'm
known
coming out of the balloon.
right
down,
away.
we got to go back up.
You know,
Right.
especially if the
We're hanging out.
anesthesiologist
It's
or
very
whoever just
big.
doesn't
you're
tell
gonna-
us
you're
about
gonna
the
decide.
pressure difference. So
You go up there.
I think doing it awake, you get real-time
pretty
kind of
quite a bit
feedback
of-
from the patient too. But it can make it a little more challenging, of course.
Ajit, what kind of blood pressure do you warrant for preventing any spinal complications?
Yeah, good question. So in this case, I think we discussed the risk is low, but things that we typically do are increase the blood pressure. So at least
5?
maps above 80
6.
to 90
Okay.
for the first 1 to 2
Coronary,
days.
please. Coronary.
So I think that's what we, in this
seen it.
case, we should hopefully, if his blood pressure doesn't stay up there on its own, we could, put him
Yeah.
on intermittent pressors for the first day or two.
Mm.
If in high-risk cases, which is not this one, you could consider a spinal drain.
Spinal drain, yeah.
Yeah. So again, if there's like multiple risk factors, like treating more than 20 centimeters of aorta, covering the subclavian or celiac or the hypogastrics or something like that, then I would definitely consider placing a spinal drain.
Hold on, just take this out.
And yeah, or like trying to open up if you are going to cover subclavian or hypogastric, trying to revascularize.
Super core again.
So those are some things.
Beautiful,
but I think in this case, we'll just keep the blood pressure up.
So nice. It seemed that even despite the 16 that there is, or the XXL, there still was quite a waste.
Yeah, I mean,
yeah.
I think it's just the recoil with the lumen, like you said, of the vessel itself. I think that's the maximum you're going to get.
It certainly did expand, but the waste was still definitely evident. But I think, as we were saying, great is enemy of good here. I think there is a very reasonable reduction in the gradient, less than 10.
That's a very good point.
So we still have a high gradient. We have a gradient of 40.
Wow.
40.
Still, yeah. Let's zero both, please.
Well, I don't know. I mean, I don't think we have a gradient of 40 anymore. We have a gradient of about 25.
No. The other thing we can
170, 150.
What 170? 150, and the other one is 120.
It's 30 millimeters.
Yeah, it's about 30. We can do one more inflation.
Well, it's down 30%, but yeah, exactly. Maybe just.
I'll do one more inflation.
If we IVUS and we see that the lumen is expanded, at least a couple of millimeters, then I think, if there's some improvement there,
let's do one
we can just monitor it.
But I mean,
right here.
I mean, we already went up to 6,
the last thing we want to do is rupture.
Let's IVUS one more 6.
You want to go, but you think?
Yeah, one more 6.
Okay,
one more 6.
No, we have bigger balloons. One second.
No, the bigger balloon is no sense because we have a waste with this balloon. There's no
can you get the shutters on the right side out so that way it just gets a better visualization?
There you go.
Thank you. Oh, sorry, left side of the patient. My bad. So.
Okay, go up here.
Left, right.
See on a Wednesday morning.
Let's go up here.
All right.
The other, option, especially when we do dissection cases, is the stent may expand over time. So this has a lot of radial force.
Tell me it's not this. I don't think it's going to. That's a
I
good idea.
Yeah,
I like this. I like this.
This is just
me convincing you. I like this optimistic situation.
This is just me convincing you not to. Yeah.
Wow.
I love it.
Yeah. But
except that I don't know about it.
Yeah, so in this case, I hear you because the native aorta is small to begin with, so it's going to be hard for it to expand on its own. But in other cases, it's definitely a consideration.
All right, let's get the IVUS ready, guys.
It looked like this time you went a little bit higher than 5 on the.
No, it wasn't.
No, it was 6 again.
6.
Same.
Oh.
Let's walk this out. Get the IVUS. Get the IVUS on this sheet, on this wire. Get the regular. No, we'll do it on this. We'll do.
No, but let's put this thing.
You want to take a picture, PK? No, not yet.
Why? I mean, just do an IVUS.
No, we'll do an IVUS. So why? We have this next to the IVUS. Why not?
So many inflation. Okay.
Make it better. Look better. Hold it, please.
Yeah, I think in this case, IVUS is going to be much more useful.
I totally agree.
Because, we already did an angiogram, and you see a flow lumen.
Exactly.
But now we need to know exact sizes.
All right, let's walk this balloon out of it so we can do the IVUS on this wire.
You have sheet?
Yeah, I got the sheet. Let's get the IVUS to me, please. Wire.
I guess the moment of truth.
Well, I think, I mean, truth-wise, I think we're good. I mean, it's just a question of now the gradients, right? I mean, it's about a 30 millimeter gradient across it. And, what I'm concerned about, give me the IVUS, please. What I'm concerned about is that, the issue is going to be whether we've done a good job after doing all this. And, and we put this man through this procedure, and the idea would be, is he going to have a symptomatic relief that he needs?
Yeah.
And that's kind of the worry that I have right now with this much of a gradient.
I agree.
What's the wire, guys?
It's what are we looking at the anatomical success, or are we looking at the physiological success, or a combination of both? So I guess we have to draw on
your considerations at this point, given the fact that you are protected with a covered.
See, it's still very enfolded. You can see that.
Wow.
Yeah.
Ready? So we might have to put a stent inside his. Ready for pull? Wait, record.
Let's record. Yeah, let's do a whole IVUS.
Stent right at that level.
See? Wow.
See the unfolding there?
What is that? Well,
that's the wire. That's the wire.
That's the wire. That's good. No problem. No,
nothing
over
major
here
there.
is the critical part.
This is
Let's
the part we really need to look at.
There it
Right
is.
there.
Not as enfolded, but
it's
it
definitely
clearly
better than what it was.
What's the MLD in
Well,
that
of
area,
course.
please?
We'll have to
Let's
measure
look at that.
All right, and we're outside the
All right,
stent
we're
now.
fine. We're good. Okay, let's go to the smallest area. Stop the imaging, please. Stop the imaging, please.
So
Do you think?
the question is, why not put a stent inside?
Just worry if it
because
doesn't expand, then it's going
I
to be
think we
even
have to
more
do shockwave if
occlusive.
you want to do anything else,
you know?
because the calcium is restricting.
Because
Yeah.
it's
But
already
the problem
set to
is-
some extent.
Why do
Yeah.
you do shockwave on the outside?
But I don't think it'll get through the fabric, though.
Yeah, I don't think
Yeah.
it's.
It will get to the fabric. Why not?
What about
I think the
Dorado?
question is not the radial
I
strength
think
of
the
the
only other
stent,
option is just
Raman,
using
but
a
I think
higher
it's
pressure
more about
balloon.
the expansion of the
Dorado,
lesion
right?
per se.
That's the only other option.
So
we
putting
have.
another,
What's the?
I don't know. That would
what's
be
the-
my opinion. Is
what,
like,
do you have an atlas?
I mean, I understand if it's a self-expanding
let's see what
nitinol
they have.
stent,
Let's
it takes
So
time
yeah,
to open
so
up in 48 hours.
so guys, I think let's walk.
8x9.
Yeah, we haven't really improved it a lot. So I think what we're going to do is we're going to use another a non-compliant balloon.
Atlas balloon.
Let's walk this out, the IVUS. And what so we talked about putting another balloon expandable stent. Problem is, if it doesn't expand, you're in trouble. You already have a self-expanding stent in there.
That's right.
So what we're going to do is we're going to go get
what
a
16
high-pressure
balloons do you
balloon, which is what I'm going to do right now. So we're going to leave you with Dr. Dangus.
Yeah, let's get a high pressure balloon.
Okay, guys, let's go.
You know, and see what we get. The gradient is 30 right now, which is half that it was. It was 60, now
Right.
it's 30.
Can we
Definitely.
see the?
All right, we're doing very well.
So the area, the luminal diameter did increase, but again,
Yeah.
not to the optimal level, I guess.
Very challenging case. It's always, case
So
planning is always a
as
very
we
tough
said,
thing to
we're
do
at
here.
30. Optimally, we had decided ad hoc that we would stop with a successful result if we were under 20.
Correct.
So we're very good. At least that's what my goal. So, I think we're very close.
Yeah, I think there's a 50% drop in pressure. It was 60 to begin with, now it's 30.
Yeah.
But you're right.
Yeah, it was tremendous. It was 60 plus today,
Yeah,
actually.
exactly.
60 was the previous time, 60 plus, and now we're 30. And I think we're in the way to make it a little bit better if we can with an extra ballooning. That's fine.
I think that's a very good point.
Let's
Like we were talking about
What's
this
the
case,
biggest
it's mainly
shockwave
the
diameter?
7.0.
Was it a 7.0?
7.040 is the smallest. So you could use
That's bigger.
You can always use two.
another side balloon to really
10 balloons.
Yeah.
Two short 10s from both sides.
both
Who
sides.
can use two shockwaves?
Well, technically, there are people who've tried two shockwaves on the side and just try
Yeah.
to, again, everything is off-label. Let me put
Yeah.
it on the
Who can try
market.
two
Post
shockwaves
stent.
as a possibility?
So
But let's see
technically,
how
it's
it
not
goes with this
recommended
balloon.
after stenting. It's before pre-stent
Yeah.
modification. So this is all will be just salvage technique, I guess, to
Oh,
say
it's
to make sure
salvage.
we get.
Yeah. I mean,
This
clearly,
This is contrast.
to go do that before would have a risk of rupture. Nobody
Correct.
wants that.
Of course.
It was a very tricky thing. So right now, we'll take the off-label versus the rupture.
No, I definitely agree to it. It's just for the audience to make sure these are
Yeah.
all the things to
Not
look
the first
forward
line
to.
things that
Yeah.
you're planning on doing.
Exactly. That's why we need great minds on the table right there.
All right. Where is it?
So what's the plan, PK, now? What do we have in your hands?
We have a Vita balloon 16,
Vida balloon.
and we're going to go up. It's a very focal balloon.
Yeah.
So you
Now
can
we up
see
to the
here-
BAV territory.
I guess I'm a specialist with this type of
I was
balloon.
going to say, Dr. Taggers, that his structural territory kicks in now.
No, a little bit higher, please. There you go. Wow.
Maybe a little bit of extra sedation so he can tolerate for a longer period of time might give you a little bit more result. Ooh. Wow.
Very tight.
Oh, it's a very focal balloon. Come a little bit back.
Mhm.
Yeah.
Do you want to use a balloon, a insufflator?
I guess.
When it's a
Yeah, let's get
volume
an insufflator,
expanding.
guys. Yeah.
Yeah, we
Let's
got
get
one.
an insufflator. It might be easier, George, for you.
Yeah.
Yeah, let's do that.
One
Yeah,
second.
remember
Let's do a
Vita
half
and all
half.
are like, yeah.
Maybe do some with this.
And do the rest with the insufflator.
Yeah, it's a volume
go with the
expanded
deflator
balloon
now.
rather than a pressure expanded balloon. So that's why I have to do a hand injection to it.
All right, we're up to 6,
Yeah, the pressure.
Sine, please, are we coronary?
Yes.
Sine.
You just want to see the exact. Yeah.
Keep going.
Yeah.
Oh, it's amazing. The balloon does expand well. It's not that it's not expanding. It's just that probably the
I think we
recoil
did a
there.
good job. Okay, I think that.
Yeah,
I think the recoil
now it
there
looks
is
good.
Yeah.
The question is the recoil legit. Whether we
Yeah, I think that's the recoil.
I think we got it. We got it.
I think it looks better.
We got it.
I think we should take a picture.
I think this is great.
Oh,
Okay, let's get back to get the pigtail up again. Super core again.
Let's see if it goes.
Nope. All right, there's some here, Ajit. There's some learning for Ajit now. The Vira balloon, Ajit, for you.
Oh yeah.
You can go back to the
they
OR.
don't have that in the OR.
I was gonna say.
Special.
We'll give you.
BAV balloon, guys. That's a BAV balloon.
We'll give you one as a gift for thank you for coming here.
Yeah.
One Vira balloon.
They might suddenly disappear one day.
Okay, very good.
If it works for Vida, come.
Yeah, but that looks a lot better on the fluoroscopy.
Bingo, under 20. Under 20. Only one thing I have to say.
Guys, let's walk this balloon out from this sheet.
Yes, and under 20.
And let's zero both, please.
Yeah, where was zeroed?
No,
we are waiting for PK to smile as well. Once he smiles, that means the case is done now.
No, we're gonna zero both. Hold on.
See?
Where's the? Oh, you got both there. Zero both, please.
Zero.
Here, show us.
Telling you it's less than 20, you don't believe me. It's exactly 18.
Can we see the tracing?
Gradient is exactly, show the hemodynamics, please.
Yes, please. Can we see it?
Top
you want to
right
see that
screen,
excited?
above that. There you go.
Yeah, much better.
Much better.
Bingo.
All right, let's do a DSA, guys, from above.
Guys.
Let's do a DSA.
I think that's very acceptable.
Successful procedure.
Ready? Okay, ready?
Excellent.
Yeah.
Fire.
Oh no, so 1 second. It's not.
One second.
Nice.
No, we're done. We're done.
Beautiful.
Beautiful.
Yeah, I think we're done. I mean, I'm just.
Unless you want to showcase the rest of our BAV.
All right, guys. Vita balloon did the trick.
Do you want to repeat an IVUS, PK?
In all honesty, this resembles the aortic valve stenosis characteristics of the calcium and all that. So no wonder we're using a valvuloplasty balloon.
So
whatever works.
It is 126, and so it's about a 20 millimeter gradient. A little
it's
less.
not a 20. It's 18.
It's 18.
Under 20.
It's signed
George is
18.
absolutely right.
Under 20.
I think.
Do another IVUS?
I think we should do another IVUS.
Let's do another IVUS. Keep it here.
Oh yeah.
The area diameter is more than 10.
Yes. All right. So good. So at least the physiological aspect is taken care of.
Well, I just want to make sure there's no infolding or anything like that. That's all.
Right.
Yeah, it would be nice to have. So for Twinkle's presentation in upcoming meetings, it's a memorable case.
Yeah.
Absolutely. Yeah. Get ready, Twinkle.
Yeah.
Yeah, absolutely.
Yeah, nice case.
Yeah, here's okay. It's good.
Okay, let's start here. Okay, ready?
All right, let's go there. We'll go a little bit higher there.
There you go, yeah.
All right, ready?
Record.
Record.
That's good right there.
That's very good.
Really stop here.
Expanded.
Bookmark here. Bookmark.
That's just
okay, keep coming.
Yeah, so this is
bookmark.
This is where we were narrow before.
All right,
yeah.
we'll come out.
That looks pretty good.
Which is
beautiful.
very well.
Oh, yeah.
All right, do the diameters in the two bookmarks, please.
We're good.
Beautiful.
All right, we're done.
Very nice.
Okay, so again, I want to thank Dr. Rao for really taking time to come here to us. I mean, it's an amazing case that we just showed. Very difficult, a lot of difficult decision making, as well as challenges. It illustrates the ability of nursing, good nursing, as we all need and appreciate.
And the other one.
So therefore, you could see that we were able to, all the talking points were there.
Oh,
Thank Dr. Dangas for taking time out of his schedule for being here, and Twinkle for such a great presentation. We'll see you guys next month. So thank you again.
10 by 13 by the in the diameters now.
Now it's very good. We're very
10
good.
by 13. So
and
we
the
have
gradient,
an
the
MLD
gradient
of
is
10.
also coming down, so we're good.
Yeah.
Thank you, guys. Thank you. See you next
Thank
month.
you very much.
Thank you.
Exceptional case, and everybody,
Incredible.
we look forward to having you with us for next month's live case on the end of the month, on March 30th. And thank you again for joining us.
Thank you.
Have a good
day.
Bye-bye.